80%. That's what one wrong VA door can leave a TRICARE for Life user owing. Professor Beaulieu studies how federal health programs divide responsibility when coverage overlaps. There's one number that quietly changes the bill at one exact TRICARE for Life wrong door.
So now, Jasmine, that sounds backwards. If both coverages are active, why is there a wrong door?
Because VA healthcare is one federal care system, while TRICARE is a separate coverage program. Eligibility for both gives you options, but it doesn't combine their referrals, copays, pharmacies, records, or claims into one plan.
Usually, I'd not begin with the card in your wallet. Begin with the care being delivered today, who authorized it, which network status applies, and which claims processor will receive it. That decision controls every handoff that follows.
What VA's own current page establishes is this: a retiree can use VA healthcare along with TRICARE. It also says other insurance doesn't change the VA care that retiree can receive.
This map is only for someone whom VA and TRICARE have separately found eligible. It doesn't create eligibility in either system.
So the myth is that one program cancels the other.
Right. A retiree may choose VA for service-connected care and TRICARE for other care. The clinical conversation can look familiar, but only the chosen administrative lane controls the claim.
In most cases, I'd not let service connection lock every appointment into one building. The January joint briefing says a retired member may receive that care through either program. What matters for the claim is which authority actually delivered and authorized this encounter.
That distinction matters. We are not announcing one permanent winner. We are teaching a visit-by-visit route decision.
A person can have two keys. The mistake is expecting both locks to turn together. That's the rep. Choose, verify, document.
Exactly. Before a routine appointment, decide whether it's VA care, VA-authorized community care, or TRICARE care. Then verify that lanes network, referral, and authorization rules.
If a VA facility will treat you under TRICARE, tell registration before the visit. The January 2026 joint briefing says to identify TRICARE as the benefit being used. I'd want to check the facility and contractor record too, because network status can change.
Professor Beaulieu, give us the sentence a beneficiary can use at registration.
Say, I am here under TRICARE for this appointment. Please confirm you are billing TRICARE, not opening a VA encounter. Then ask the desk to repeat the payer and network status back to you. Chris, which 3 items will you repeat before you leave the window?
Benefit, payer, network. Now repeat all 3 before treatment starts. RIP complete.
My reading map only works because every flag keeps its source. This care map works the same way. Each appointment needs one source of authority written down before the claim exists. This paperwork is generic, not a VA or TRICARE form. It represents the question to write at the top: which payer authorized this care?
Erica, I want to test the handoff. Can my VA doctor simply refer me into TRICARE?
Only the responsible authority can authorize it, Chris. The care team can recommend cardiology, but the responsible payer still has to issue its referral or approval. My card catalog works because every drawer is labeled. Your care record needs that same discipline.
No, wait. The receipts say the medical need and the payment permission are separate facts. One document cannot silently stand in for the other. Free coordination guides are at vaprofessorerica.com. Use them to organize questions, then verify each path with VA and your TRICARE contractor. Next up, one referral number separates clinical yes from payment yes. One thing before the next part, and then we move right on. If any of this is clicking, tap that like, hit subscribe, and ring the bell for the next one. It takes a second, it costs nothing, and it helps more than you would think.
A medical recommendation doesn't create a referral number, so start there now.
A retiree wants cardiology. The VA care team agrees it is appropriate. What happens next?
First, choose the lane. Only then may the VA team schedule inside VA or authorize community care, or the beneficiary follow the TRICARE plan and regional contractor rules.
That's the door decision. Pick the door before you sit down.
What the TRICARE Prime guidance says is this: Specialty care generally needs a referral from the primary care manager and pre-authorization. The authorization letter names the provider and expiration.
For TRICARE Select and related Select plans, most procedures don't need a referral, but some still need pre-authorization, and the provider must be TRICARE authorized.
And now the trap. A VA facility can be in the TRICARE network while the appointment still fails the authorization test.
Correct. TRICARE says most VA facilities are network providers, but the beneficiary should check with the regional contractor before making the appointment.
The page gives retirees a useful default: VA for service-connected conditions and TRICARE for other care. This is guidance, not a ban on choosing differently.
Run Morgan's cardiology visit. Morgan is retired, enrolled in TRICARE Prime, and also gets VA primary care. The VA doctor agrees cardiology is medically appropriate. What document is still missing?
A TRICARE referral and authorization if Morgan chooses the TRICARE lane. The VA note proves medical judgment. It doesn't prove the regional contractor accepted the specialist, dates, or service. If Morgan instead chooses VA community care, VA must approve that outside appointment before routine care.
This raises the uncomfortable question: what if the right cardiologist is still the wrong payment route? That happens when the required approval is missing.
Hang on. So now Morgan checks 4 fields before the appointment: approval number, named clinician, procedure, expiration. 4 beats 1 vague promise. What about a VA primary care provider acting as the TRICARE primary care manager?
To be precise, only when the person is actually enrolled with a VA TRICARE provider through the contractor. The joint briefing says TRICARE primary care is separate from VA primary care. You can't use both as one blended primary care relationship.
That closes a common gap. The same building doesn't mean the same plan.
Build the routine care checklist now without pretending every plan is identical.
1. Name the benefit. 2. Confirm the clinician or facility under that benefit. 3. Obtain any referral or authorization. 4. Check the dates and procedures on the approval. 5. Tell registration which benefit you are using.
The waiting room handoff is where the administrative choice becomes a real visit. Make the choice before your name is called.
No referral needed isn't the same as no rules.
A medical recommendation isn't proof the contractor approved it, because only the portal or authorization letter may establish approval before routine care.
What if Morgan's authorization names the right specialty but the wrong provider?
Call before the visit. Don't assume the practice can substitute another provider, location, or procedure under the same approval. Ask the contractor to correct or confirm the authorization and save the updated notice.
So now a correct specialty with the wrong name provider can still be a failed rep.
Chris, give Morgan the line to remember.
Clinical yes isn't payment yes. Get the number, clinician, procedure, and dates before routine specialty care.
Back with us for the billing handoff is Professor Beaulieu. A statement arrives after VA care, but the largest printed number may not be the beneficiary's debt. Professor Beaulieu, when VA has TRICARE information, who is VA actually billing?
Usually, I would ask why VA collected the coverage data. For treatment of a non-service connected condition, VA says it must submit eligible charges for care, supplies, or medicine to private health insurance.
VA doesn't bill Medicare or Medicaid. It may bill Medicare supplemental insurance for covered services, while a TRICARE claim follows the member status and the system used for that encounter.
Does other coverage reduce VA eligibility?
No. I would separate the 2 records. VA says other insurance doesn't change the VA care an enrollee can receive. The coverage card opens a reimbursement branch. It doesn't close the eligibility file.
Then what happens if the insurer does not pay everything?
In most cases, the beneficiary doesn't owe the insurer's unpaid balance, but a VA copay may still apply for non-service connected care based on priority group. Those numbers come from different rules, so never treat the explanation of benefits as the final VA statement.
That distinction matters because only the explanation of benefits shows what the insurer processed, while the VA statement may show a VA copay actually owed.
What the receipts say is this: A large billed charge isn't automatically a bill to the patient. Before we get to the pharmacy handoff, the 80% bill has to survive one narrow TRICARE for Life test.
But even when VA could see you,
TRICARE should pay anyway. That's the instinct, Erica, but eligibility alone doesn't create a payable claim. Provider status, authorization, and the chosen system still control.
Exactly. A VA encounter doesn't turn into a TRICARE encounter just because the patient also carries TRICARE. Which authority opened this door, Chris? The care record must answer that.
the published record settles the flip side. A third-party payment to VA can offset part or all of a VA copay, and the insurer may credit the VA charge toward a deductible.
Erica, the hard version is, does the veteran owe the insurer's unpaid balance?
No, Chris, to be precise, I would not treat that unpaid insurer balance as the debt. Verify the separate VA copay on the VA statement.
So now we don't erase the number, we label it correctly.
2 numbers, Chris, 2 documents. Keep the explanation of benefits beside the VA statement, and write which system handled the visit. That paper trail is calmer than reconstructing the encounter months later.
I would check the exact statement before judging the balance. Then use 3 columns: insurer action, VA action, veteran action. Verify each document and dispute only the amount actually assigned to the veteran.
That keeps a scary billed charge from becoming an automatic payment.
Because the claim and copay are separate, the paperwork must stay separate too. The prescriber, not the building, will control the pharmacy handoff.
Professor Ballou, thank you for separating the claim from the copay.
You also killed the blended plan myth.
Keep the route written down. Jasmine, which document will you label first?
One question remains. Where can most of the bill land anyway?
The remaining balance may be 80%, but only because one narrow route changes who can pay.
This is the bill we held back in the opening.
A TRICARE for Life beneficiary receives non-service connected care at a VA facility. The corridor looks ordinary. The payment route is not.
The qualifiers do all the work. A TRICARE for Life beneficiary gets non-service connected care at a VA facility while using TRICARE for Life, not the VA benefit. Medicare can't pay that government facility. TRICARE says it may then pay only up to 20% of the TRICARE allowable charge. That can leave the beneficiary responsible for the other 80%. This is not a universal VA bill, and it is not a warning against using VA for covered service-connected care.
Which means this: TRICARE may pay up to 20%, so as much as 80% can remain. Riley's hypothetical allowable charge is $1,000. Up to $200 may come from TRICARE, which means as much as $800 can remain. The actual claim depends on the covered service and allowable charge, but the percentage explains why choosing the provider before routine care matters.
Erica, that's not a small copay. It's a route-level cost shift.
Fair point, and it doesn't tell a veteran to avoid VA for service-connected care.
Correct. TRICARE and VA recommend VA for service-connected disability care. For other TFL care, a Medicare-certified provider is usually the lower-cost route when Medicare and TRICARE both cover the service.
That pays the promise, but the exception matters. This warning isn't for a veteran using the VA benefit for covered VA care. Now the harder question is, what happens when a medical crisis leaves no time to choose a door?
Emergency first, billing second. So now, if a reasonable person believes there is a medical emergency, call 911 or go to the nearest emergency room.
TRICARE doesn't require a referral for emergency care. A prime enrollee should call the primary care manager within 24 hours or the next business day afterward.
The desk will know.
Hospitals treat the patient, not your benefit crossword.
That was annoyingly good. The patient or representative still has to make the follow-up calls.
What VA says is this: emergency coverage has its own eligibility and notification rules. VA must receive notice within 72 hours after non-VA emergency care begins for the timely notification route. That deadline doesn't guarantee payment, because eligibility still has to be determined. Boundary test: Do those 24 and 72-hour clocks decide whether someone should go to the emergency room?
No. The medical emergency controls where the person goes because later notifications only preserve possible coverage routes. Don't delay treatment to solve the billing map. Afterward, notify each authority that might lawfully cover the event, say where care occurred, and keep each call reference.
Change case. If it was routine urgent care, the same rule means those clocks do not apply. Ordinary referral, network, and authorization controls the route.
Right. The decision rule changes with the case. Those notice clocks apply only after crisis care. Routine urgent care stays under its ordinary referral, network, and authorization controls.
Those clocks may preserve a possible claim only afterward because they never manufacture the medical event before care.
So now comes the follow-up. Verify authorization and the next appointment before the hospital record disappears into separate portals.
Crisis care buys time. It doesn't merge the programs.
Right fact, right deadline.
Hold on. Different animal entirely. Prescriptions.
I mean, one bottle can expose the whole coordination problem.
VA pharmacies fill prescriptions written by VA providers.
So now TRICARE uses the TRICARE pharmacy program.
Which system should fill a prescription?
Name the prescriber who wrote it.
A VA prescriber wrote this one.
Here's the ruling. Use the VA pharmacy route. That is the answer we parked earlier.
A civilian TRICARE prescriber writes another.
That goes through the TRICARE pharmacy options and formulary rules.
The danger is not merely inconvenience, because separate records may hide duplicate drugs or interactions.
Carry one current medication list to both systems.
Include dose, schedule, prescriber, and the pharmacy filling it.
Suppose the VA prescriber changes a blood pressure medicine on Monday.
Then a TRICARE specialist sees the veteran on Thursday.
If Thursday's chart still shows the old dose, the specialist is making a decision from stale information.
The portal didn't lie, it simply never received Monday's change.
So bring the list, say what changed, and ask the care team to reconcile it. That's the rep every visit.
Let me back up. A printed list, a phone note, or a patient portal export can work. The tool matters less than the date, dose, prescriber, and last change.
Erica, what belongs on this master record beyond medicine, and which fields travel between systems?
Provider, diagnosis, referral, authorization, prescription, follow-up, and which system paid or denied. The federal systems can coexist, yet the veteran is still the bridge between their records.
Build the shared record yourself.
For every visit, record benefit, provider, referral, authorization, diagnosis, prescription, and follow-up.
That's the door decision returning. Same phrase, bigger job.
The last checklist is intentionally short. No wait, short but complete.
Before care, choose only one payment route because its authority must be verified.
During care, tell the desk and care team which benefit you are using.
After care, save the record, explanation of benefits, VA statement, prescription, and next step.
Stop there, that's my lane. Write the system used across the top of every saved page. This is the couch to 5K rule. Every run needs a lane and a log.
Yes, that label prevents a future helper from joining the wrong dots.
This complete coordination card answers what to carry in 6 lines. Send this checklist to the retiree in your circle who carries both cards but still tells every front desk, just bill whichever one works. Be the person who helps them choose before the appointment, instead of untangling it after.
That sentence alone can save an afternoon of contractor calls. So now keep the chosen lane visible. 2 federal health systems only help when the handoff is logged.
Here's what I would recommend. Choose one payment authority before routine care. Verify its approval and carry one master record across both programs. That is the safest way to keep both benefits without expecting an automatic handoff.
Walk away with this. 2 doors can serve you well, but every visit needs one labeled key.
Use the current official pages and your regional contractor because plan rules and provider networks can change.
Next time, we'll map the VA emergency care notice that can protect a community hospital claim. If this clarified the handoff, like the video and subscribe. Which record would help you most tonight? Authorization, explanation of benefits, or medication list? Keep every door labeled. Until next time, take good care.